Our next speaker for the keynote is Dr.C.N.Purandare. Welcome, sir. He has over 40 years of experience in women's healthcare, former President PICO and FOXY, Emeritus Deans, ICOG, Honorary Professor at Crown Medical College and JJ Hospital, awarded the Dr. B.C. Roy Award. He will be speaking on what do we think of osteoporosis management.
Good evening, everyone. We're already delayed today with the airlines contributing to it by some of our delegates who have arrived late. I managed to get out of Delhi in the morning, so I was okay. Those who started in the afternoon with the traffic, etc., everything is delayed. Anyway, all the same, Nandita has more or less covered everything that needed to be talked about when you're talking about the osteoporosis and the advantages. The osteoporosis management as far as the vitamin D need starts from childhood to adolescence to pregnancy, right up to menopause. And this is not something which is a problem which is we're going to face at the age of 50 when women are closer to menopause and we deal with it. It has to be looked into in a holistic approach right from the beginning to the further on in life. So what do we think of osteoporosis management as far as obstetrics and gynecology is concerned? The osteoporosis is a bone disease that weakens bones and making them susceptible to fractures even from minor falls or everyday activities. When you look at all the women that take treatment from a gynecologist, you realize that after their pregnancy is over, they feel that it's not necessary to go to the doctor. Their job is over, pregnancies are over, unless somebody has heavy periods or some other problem. Pap smear is again unheard of, people don't even bother. And so also looking at the calcium levels and vitamin D levels, and as Nandita said, 90% of them have poor vitamin D levels. So it occurs when bone mineral density and bone mass degree is leading to reduced bone strength. And mostly referred to as a silent disease because it doesn't usually cause symptoms until a fracture is seen. So women per se don't bother checking it, and unless as a routine things are checked in as some kind of a package, nobody even bothers checking whether what their vitamin D levels are. And it's a chronic disease affecting 1 in 3 women and 1 in 5 men over the age of 50 years. And it's globally seen. Now, at this point in time at least, the gynecologists, if women come to them, we tell them that after the age of 45, taking calcium is must, fairly high. And why are women at more risk? Just because osteoporosis can occur at any age, although risk of developing the disease increases with age, and for most women the disease begins to develop a year or two before menopause due to estrogen depletion. Estrogen depletion is something which is a gradual process and women don't bother checking it whether what is happening unless there is a fracture or menopausal symptoms are evident in terms of maybe hot flashes or dryness of vagina or whatever the other situations are. So the bone loss and premature ovarian failure, cancer medication and long-term steroids make a lot of difference as far as the osteoporosis is concerned. Now you are all aware that the cancer has become a very highly prevalent situation as far as women is concerned, whether it is cervical cancer, breast cancer, ovarian cancer, and so on. And most of them are silent cancer and are detected very late. Cancers, when medication is required, you require chemotherapy and so on, and those affect the bone density as well. There are no typical symptoms in the early stage of bone loss, and once bones are weakened by osteoporosis, they include back pain due to broken or collapsed bones in the spine, loss of height over time, a stoop posture, or a bone that breaks more easier than expected. So the classical description of in a woman is called as the dowager's hump, when the osteoporosis causes bending of the woman, loss of height, and kyphosis, which is a chronic pain, and that's the time when people realize that there is something grossly wrong. The normal bone remodeling balances between osteoblast, which is formation, and osteoclast, which is resorption. The type 1 is the postmenopausal, where estrogen deficiency, which causes activity. While type 2, which is a senile aging, which causes diminished osteoblast function and vitamin D deficiency. And the secondary causes, of course, are steroids, hyperthyroidism, and chronic inflammation. So when you look at the classification of osteoporosis, you look at two different parts, the primary and the secondary. The primary, which are happening in the postmenopausal, type 1 and type 2 in senile, while secondary, which is happening with drugs and corticosteroids. The factors which are non-modifiable, which are age greater than 50, are in a female, family history, race, body frame, and modifiable are the ones which are low calcium, vitamin D3, alcohol, smoking, sedentary lifestyle, eating disorders, and medications. If you look at the diagnosis with DEXA scan, risk factor, Nandita mentioned about the risk level where you have the high, intermediate, and a low level with DEXA, and the division when it takes place where there is OP, which is yes or no, and if it is yes, the pharmacological treatment that needs to be done, as against the lifestyles that need to be rectified. My perspective on osteoporosis is that it's a silent thief. Steals bone density without symptoms until it's too late. It's a preventable disease. Early intervention can significantly reduce risk. And a growing burden. With aging population, osteoporosis is a global health crisis. When the average age of a woman was 60, you never saw so much of aggressive osteoporosis and bone fractures. But people are living up to 90 now, so that makes a major difference as far as the situation is. There's lack of awareness. Many people don't realize that they are at risk until a fracture occurs, and seen as a normal part of aging rather than a preventable condition. Thinking that this is going to happen to everybody, irrespective of what, and it's not preventable. So delayed diagnosis, screening, DEXA scans, etc. is often underutilized. The impact of osteoporosis, when you say the physical impact, is the fracture, emotional impact, which is the fear of falling, reduced quality of life, and depression. And believe me, in menopausal women, a lot of the times you find that the depression leads them to a psychiatrist who has only two types of medicines, mood elevator and depression. So when that is happening, the osteoporosis and depression, which is related to the estrogen lack, is not thought about. And you need to supplement them at that time with whatever form of, whether estrogen or equal substances or pharmaceutical agents, which can give a similar kind of effect, avoiding endometrial hyperplasia. So you have the soya extracts which are available, which can give you a similar kind of estrogen effect on the patient without causing endometrial hyperplasia. And the economic impact, which is the high healthcare costs for treatment and rehabilitation. So when you're talking about, I was just talking to one of the orthopedic person here, and he said that any woman coming in and requires surgery, and that surgery causes more problems and more, it just adds on and on and on, and it doesn't really look at the ultimate effect that is going to take place. So osteoporosis has a tremendous negative impact on the physical, emotional and mental well-being of a post-menopausal woman. Now you need a lifestyle modification, and when you are looking at the pillars of current management, your home safety measures are completely lacking. So you have women who are aged falling in the bathroom because there is nothing to hold them when there is a fall, imminent fall, and there are no bars around to hold them to prevent that fall and fractures from happening. And the infographics of lifestyle recommendations which need to be done, and I am happy that the media as well as the Aditi's constant messages which go on Facebook and so on give a lot of information regarding all this happening. Now, what are the pharmacological therapies that we are looking at? I'm going to give you a nutshell of everything. I'm not going to go into the details because I saw the program and literally everything is covered in that program. And I'm only the opening batsman to integrate in the situation regarding the women at large. So bisphosphatase, first line, reduce fracture risk by 50 to 70%. Then you have inhibitors, Rankle inhibitors, with subcutaneous injections every 6 months. The anabolics, which are stimulate bone formation rather than the absorption taking place. And the SERMs, which are raloxifene for spine protection in the high-risk women. And the visual mechanism diagram with osteoclast versus osteoblast targeting. So, when you're talking about the newer advances shaping management, Nandita again mentioned some of the things that dual action monoclonal antibody inhibits sclerostin, increasing bone formation and diminishing the resorption that is taking place. You have faster anabolic effect than teriparatides, which are seen in the other varieties. The digital health tools, wearables for fall detection, apps for adherence, tracking, etc. And precision medicine, which is genetic testing for LRP, P5 and the pathway mutations. 50% of the discontinuation rate of oral biphosphonate is due to GI side effects. And that is something you must realize that you need to emphasize and explain to the patient. You have anabolics which are expensive. You have atypical fractures which are long-term biophosphatase use linked to rare femoral fractures, and the underdiagnosis only 20% of high-risk patients receive screening treatment. So prevention is the key. Promote calcium, vitamin D and weight-bearing exercises which you have to highlight to the patients. And social media can certainly do that much better than one-to-one direct contact which happens with you. Encourage DEXA scans for at-risk population, especially the post-menopausal women and elderly. And education and awareness, public health campaigns to debunk myths and highlight the risks. There are stem cell therapy which has been recommended in future for future direction, still in experimental stage, regenerating bone via the mesenchymal stem cell, the universal screening for the post-menopausal women that is necessary. So in conclusion, we have to have a successful outcome. We have to save bones, anabolics, rebuild them, access inequalities and gaps to adherence challenges, fear of long-term risk, and call to action to integrate innovations with preventive, prioritize patients with education. Education is the key to avoiding the problem which is existing. Thank you very much for your patience.
Thank you, sir.